Hello again everyone, this is Dr. Habib and welcome back to the channel. Today we'll learn about reading the signs of a pneumothorax on a chest x-ray. Before looking at the x-rays, let's have a brief look at the lung physiology. This will help you understand the pathogenesis of a pneumothorax. So we have the lung tissue in green, the lung parenchyma, okay, and adherent to it is the layer of visceral pleura in purple. Around that is the layer of parietal pleura in blue, which lines the chest wall. Now this is just an illustration to make you understand things better. Okay. So in the pleural cavity, the space between two layers of the pleura, we have a negative pressure that's -4 millimeters of mercury, and the main purpose of this is to prevent collapse of the lung. It does this by opposing the elastic recoil tendency of the lungs. And you might wonder, how is this negative pressure generated? Well, the intrapleural space has a thin layer of fluid. The surface tension of this fluid helps maintain the negative pressure. A pneumothorax is a condition when there is air in the intrapleural space, also known as the pleural cavity. This can either happen due to a breach of the parietal pleura, or it can happen due to a breach of, say, the visceral pleura. So when the parietal pleura is breached, this is usually due to either a sharp or blunt trauma of the chest, say in a stab wound or in a road traffic accident. So let's say this sharp object penetrates through the chest wall and is going to breach the parietal pleural layer. Air from the outside is going to enter, and the pressure in the intrapleural space is going to increase, and that will cause collapse of the lung. Once the pressure in the pleural cavity equals atmospheric pressure, the whole lung is going to collapse on its side, and this may also progress to a tension pneumothorax, shifting the mediastinal structures, in this case, to the patient's right. This is a medical emergency. It can also happen that the visceral pleura is breached. This usually happens if, say, a patient with chronic obstructive airways disease has a bleb or a bulla, which then ruptures with it, causing a breach of the visceral layer, and therefore when you breathe in air, air is going to get in and go into the intrapleural space, and that can also be equal to atmospheric pressure and cause collapse of the lung. And the third category when a pneumothorax can happen is called iatrogenic, as in insertion of a central venous catheter or insertion of a pacemaker. Okay, so let's have a look at the next slide and have a look at which signs you need to look for on a chest x-ray to diagnose a pneumothorax. So you're going to have absent lung markings on the side of the pneumothorax where there is air filled. You'll see the outline of the lung, and in particular, you'll see the outline of the visceral pleura where the lung has shrunk down. You'll see an increase in radiolucency. This basically means that the side of the pneumothorax, it's going to appear a lot darker. The X-ray is going to penetrate more easily. And lastly, you may or may not see deviation of mediastinal structures based on the severity of the pneumothorax. So let's have a look at some X-rays. You can pause the video now and see if you can describe this X-ray. So in summary, this is a right-sided tension pneumothorax. This is the layer of the visceral pleura that you can see the outline. This is the collapsed lung here. And over here, this entire side of the lung is filled with air. As you can see, there are no lung markings, which we can see very finely and well defined over here, extending all the way to the chest wall. You basically see no lung markings over here. It's filled with air, and the radiolucency is also increased. So all of this, just change the ink. So all of this is underneath the parietal pleura. Although it's not visible, I've just drawn this out to illustrate. This shaded region over here is filled with air. So this is a massive tension pneumothorax. You can also see that the diaphragm has been pushed down. It's almost at the same level, or even maybe slightly lower than the left hemidiaphragm. It's the other way around in a normal subject. So the diaphragm has been pushed down. You can hardly make out the right heart border. You can also see tracheal deviation all the way to the left. So this is a medical emergency. This needs urgent needle decompression in the second intercostal space, mid-clavicular line, followed by a chest drain insertion. So feel free to pause the video again and see if you can spot the diagnosis. So over here, we have a left apical pneumothorax, which is small. So that's the pleural lining of the visceral pleura. And we have a small pneumothorax over here, which I'm going to shade for you. In this part of the lung, you can't see any lung markings. There's a subtle increase of radiolucency. But the rest of the lung, as you can see over here, is nice and well expanded, okay. This case may just be observed, and it might take a few weeks for this to resolve. There is no indication to treat this with either a needle decompression or even a chest drain as per the British Thoracic Society guidelines. This is a pneumothorax of less than 2 centimeters. And also to point out to you, unlike the previous tension pneumothorax we've seen, the red denotes the visceral pleural layer, and it's just underneath the parietal pleura, which is shaded here in black. So you can pause the video again. This one we can see a fairly obvious lining of the visceral pleura. So you can see all the lung markings up until this level. Now the reason they appear well defined and easier to see compared to the left lung is because this lung has shrunk, and that's the reason the markings have become a lot denser and easier to see. So therefore, the pneumothorax is on the outside here. So this is your imaginary lining of the parietal pleura. That's the visceral, and in the middle we have the pneumothorax. Do you see any further signs? Well, the diaphragm is again pushed downwards. It's at exactly the same level as the left hemidiaphragm here. The right heart border you can just about make out over there. And you can see onset of tracheal deviation to the left side. So again, this is a large pneumothorax. I think it's got early signs of tension, and this also needs urgent decompression. Bear in mind, everyone, that when you suspect a tension pneumothorax, it is absolutely necessary that you call for senior help and arrange for urgent needle decompression. Such patients ought not to have an X-ray in the first place. Moving on to the last X-ray, again you can pause the video here, and in this case we again have a small apical pneumothorax. The left side, you can just about trace it over there. I think I went off slightly over there, but you can rewind and have a look. So that's again the layer of the visceral pleura, and you can imagine having the parietal pleura on the outside. Giving the yellow shaded region as your apical pneumothorax. Now, although I don't have the precise length of this pneumothorax, if it's greater than 2 centimeters, then as per the BTS guidelines, this will require treatment. We first aspirate it, and if it doesn't resolve, we then insert a left-sided chest drain. So that concludes today's talk. I hope you found value in this video. If you have any questions or comments, please leave them below and I'll do my best to address them. I'll see you again soon in the next video. Thank you.